A urogynecologist is a physician and surgeon who specializes in conditions of the pelvic floor.
Examples of the types of pelvic floor problems that a urogynecologist would take care of might include urinary incontinence, which could be stress incontinence, can be overactive bladder, could be pelvic floor prolapse, which could involve the descent of the bladder, the rectum, the uterus, and could also involve fecal incontinence. So a urogynecologist is somebody who first went through training as a general gynecologic surgeon. So most people who consider themselves either urogynecologists or what's also called the field of female pelvic floor medicine and reconstructive surgery would have initially done a residency program in obstetrics and gynecology. They alternatively could have entered this pathway after completing a residency in urology and gone through whatever the credentialing process was to become board certified in that individual field, and then enrolled in a fellowship program, which is typically a 3-year fellowship program, which is entirely committed to taking care of women with pelvic floor problems. After the completion of that fellowship program, you would then go through the process of becoming board certified in urogynecology or female pelvic floor medicine.
Pelvic floor disorders are very common. We now understand that 1 in 3 women will have a pelvic floor disorder in their lifetime. Approximately 30% of women will experience some type of pelvic floor condition. About 40% of women over the age of 40 will have at least one pelvic floor condition in their lifetime. The types of pelvic floor disorders that we treat include urinary incontinence, pelvic organ prolapse, fecal incontinence, recurrent urinary tract infections, and painful conditions of the bladder and vagina. But the 2 most common pelvic floor disorders that we see are urinary incontinence and pelvic organ prolapse. Pelvic organ prolapse is the protrusion of pelvic organs through the vagina. Prolapse is essentially a hernia in the vagina. It's caused by weak muscles and tissues in the pelvic floor. The pelvic floor is composed of a lot of muscles and tissues that keep the organs in place. It holds all the pelvic organs up. If those pelvic muscles and tissues become weak over time, the organ that's in the vicinity of the weak tissues can protrude into the vagina, and a woman typically feels that as pressure, a bulge, or just discomfort throughout the day. There are a lot of different types of prolapse, and they refer to the actual organ that's protruding.
So if that problem is limited to the front part of the vagina, in between the front vaginal wall and the bladder, people will come in saying their bladder's dropped, and we'll call that a cystocele. If that problem is limited to the back portion of the vagina and what's called the posterior vaginal wall supports, they'll say their rectum is coming down, and we'll call that a rectocele. When the uterus comes down, it's simply called a uterine prolapse, or sometimes called what's referred to as procedentia. And again, life's not black and white, and it's very common that somebody who has a prolapse or a defect in one area is going to have a defect in more than one area. And so it's going to have element of a uterine prolapse and a cystocele, have a cystocele and a rectocele. But again, basically the common symptom that somebody's going to come in with is something's protruding, there's some vaginal pressure, there's a bulge from the vagina. For many women, there's not one thing that led to this problem. For many women, what you can sort of point back to over their history is there was something that happened 20, 30, 40 years ago that started this process. There was the birth of the 2nd child, the 3rd child, the 4th child. There was a difficult delivery. There was a period of time in their life where they were very physically active, and they were skiing, they were horseback riding, they were weightlifting, they were rowing. There were things that they were doing recreationally or occupationally that were putting a lot of strain on the pelvic floor. Maybe they'd been smokers, maybe they had diabetes, maybe they were overweight. What's also important to remember is that these are all risk factors. There are plenty of people who don't smoke that get lung cancer. There are plenty of women who are not overweight, who do not have diabetes, who do not smoke, who wind up getting pelvic floor problems and symptomatic pelvic prolapse. So if you look at women who are, 60, 70 years old who are coming in with a pelvic prolapse, they've obviously also all gone through the menopause. So if their tissues were strong enough to remain intact and to hold up the bladder, the rectum, the uterus, despite having had these injuries when they were younger, once they've gone through the menopause and the collagen that makes up the ligaments that hold up the uterus and support the bladder, once that's altered, very often at that point, there's not enough left in the pelvic floor. The levator muscles that make up the pelvic floor can't provide enough structural integrity. And so the combination of the risk factors that may have first presented many years ago, having gone through the menopause, continuing to lead an active life, will ultimately lead to a failure of these supports, to a herniation of the bladder, of the uterus, the rectum, and a patient presenting with prolapse. It causes discomfort. It affects somebody's quality of life because they're always aware of this. If it's the bladder that's dropping out, one of the symptoms that's very common to a bladder prolapse is the inability to empty your bladder completely. If you can't empty your bladder completely, you're going to feel like you constantly have to go to the bathroom. When you go to the bathroom, you're not going to feel relief that you were able to empty your bladder well. You're going to start to avoid social situations because you're going to feel the constant need to use the bathroom. When you go to the bathroom, you're not going to be able to go in and come out quickly. You're going to feel the need to sit there for a prolonged period of time to try and empty your bladder. The same type of thing happens with a large rectal prolapse or with a rectocele. Because of a kinking in the rectum, as the rectum herniates or protrudes into the vagina, many women will find it very difficult to empty their rectum. And so it was, for many women, it was a state of constipation that led to the development of this prolapse. And now that only becomes worse and more severe and more significant because the stool gets trapped in this hernia pouch that's basically sitting inside the vagina. And so there's this constant feeling of bloating and inability to empty, and inability really to feel clean, I've heard so many times. And it could dramatically affect somebody's quality of life by having them avoid situations where they would feel self-conscious about these problems.
The non-surgical options for this condition include pelvic floor exercises, physical therapy with biofeedback, or the use of a pessary in the vagina. A pessary is similar to a diaphragm that was once used for birth control, and it functions to lift the prolapse so that a woman can feel better throughout the day. This is not a definitive treatment, meaning that when the pessary is removed, the prolapse still exists. Pessaries are great options for women who are not surgical candidates or who have several medical problems that prevent them from undergoing surgery. They're also a good option for women who find discomfort with particular activities throughout the day. A pessary can be placed when the particular activity is performed and removed at the patient's discretion. These pessaries are not definitive treatment options, meaning when the pessary is removed, the prolapse will still be present, but they can significantly improve a woman's quality of life if surgery is not an option. Minimally invasive surgery with the laparoscopic approach or the robotic-assisted approach can often lead to a return to normal activities more quickly for a woman. A vaginal approach is also considered a minimally invasive approach and may be a good option depending on the type of prolapse. Women who undergo surgery for prolapse can find significant improvement in approximately 80 to 90% of cases. As a board-certified urogynecologist, I would urge you to talk to your physician if you experience symptoms of urinary incontinence or pelvic organ prolapse, and discuss whether a referral to our program is appropriate for you.